Let me introduce you to Ben. Ben has suffered a stroke and will be now taken to your clinic. When would you start rehabilitation treatment, and what kind of treatment would you select? An estimated 1 billion people worldwide are affected by neurological diseases and disorders. And if we take a closer look at the current clinical guidelines of acute strokes in different countries, it is quite obvious that patients like Ben should be mobilized as soon as possible. Nevertheless, depending on the region, when to start rehabilitation is also tied to additional criteria. Would this also have been your answer? Do you practice early rehabilitation in your facility? Hi, I'm Dr. Clemens Müller, and I would like to discuss with you the negative consequences of prolonged bed rest, the importance of early mobilization, and how to integrate advanced technologies in early rehabilitation. Today, I am accompanied by two guest speakers. Barry Ford strongly promotes early mobilization and will provide you with an insider's perspective on daily integration. He will join the webinar via Skype later on. Professor Bender is an expert on early mobilization of neurological patients with disorder of consciousness, and he will join me live in the studio in a few minutes. The main part of the webinar will be an expert panel where you can address your questions or comments to our guest speakers or to me. So please use the chat function on the right side to submit your questions anytime, and we will address them during the expert panel session. Now, let's get back to our patient Ben. He will receive comprehensive acute treatment and then lie in bed. What are the consequences of delaying Ben's rehabilitation for days or even weeks and exposing him strictly to prolonged bed rest? The range of secondary complications includes life-threatening aspects like respiratory tract infections or pulmonary embolisms. Ben's cardiovascular system would be affected by a decrease of blood volume and cardiac muscle atrophy, which lead to orthostatic intolerance. In addition, there is a major risk of deep vein thrombosis. With regards to musculoskeletal system, Ben might suffer from osteoporosis, muscle atrophy, or contractures. Going a little bit more into detail, Ben would lose up to 5% of muscle strength after only 1 day of immobility. After 1 week, his blood volume would be reduced by 10%, which would decrease his orthostatic tolerance that may already be impaired due to sympathetic failure. And after 4 weeks of immobility, Ben's muscle strength would be reduced by up to 50%. To summarize the problems associated with prolonged bed rest, Ben will face a rapid general body deconditioning and increased risk for secondary complications. To reduce such severe complications, a major goal of early rehabilitation is to mobilize and to verticalize Ben as soon as possible. But what do we know from research about this? For example, with an early mobilization protocol after acute ischemic stroke, an apparent reduction in severe complications and no increase in first complications was found. A mobility team initiated early physical therapy that was feasible, safe, did not increase costs, and was associated with decreased length of stay in the intensive care unit and hospital. And a positive impact on hospital financials could be observed thanks to shortened length of stay and fewer expensive complications. Furthermore, it was shown that early mobilization was safe and well tolerated, even in intensive care, and resulted in better functional outcomes. To have a closer look at the effect on functional outcome, even critically ill patients benefit from early mobilization. It significantly increases their chances of returning to to an independent functional status at hospital discharge. Previous studies with stroke patients have also shown that the earlier rehabilitation starts, the better the patients recover. Furthermore, we know that there's a big plastic potential of the central nervous system, especially in the very early phase. On the other hand, a study has shown that in patients with severe disorder of consciousness after traumatic brain injury, improvement may still occur even 6 months after injury. Fortunately, we have the chance to discuss this right now with a known expert in this field. I would like to introduce our first guest speaker live in the studio. Hello, Professor Dr. Bender. It's really a great pleasure to have you here in the studio as a guest speaker. Thanks for joining.
Hello, I'm happy to be here.
So, we've heard about these clinical improvements that may still occur even after 6 months. Is early mobilization still important?
Well, I think these are two different points. It is a point, and a very important point by itself, that long-term improvements and recovery of function is possible beyond even 6 months and several years. So this is, from a neuro-rehabilitation point of view, very important. But on the other hand, it's also very important and true that the earlier you start with mobilization and verticalization, the more the patient will benefit, and severe complications will be avoided. And prolonged bed rest is the single most important risk factor, it has been shown, for prolonged or severe complications and reduced quality of life, reduced body functions in the long run, even several years after an intensive care unit stay.
Okay, so you already mentioned that the earlier it starts, the better it is. Can we give a rough estimation about the timing or the start of a treatment? Is there some guidelines, or is there something also from your experience where you can say now rehabilitation or mobilization should start?
As you have shown with your guideline slide, they all state as soon as possible, but there's no consensus as to what as soon as possible might mean. There are studies which consider within the first day or second day after injury as early mobilization. Others have used the second week or even the third week as early mobilization. In my experience and in the experience of our center, for most patients, it should really be within the first couple of days. So I would say, as a general rule of thumb, as soon as you are sure that the brain condition has stabilized and there's no brain edema, increased intracerebral pressure, within the first 3 days, possibly.
Okay, so that's quite good. So neurorehabilitation doesn't only concern stroke patients like we had in the example with Ben here in this webinar. It's also patients, for example, with traumatic brain injuries or injuries resulting from hypoxia due to cardiac arrest. So what, in your opinion, what is important, or is also early mobilization important for patients like traumatic brain injuries?
Yeah, I think the same what is true for stroke patients is basically true for all patients with acquired severe brain injury, because many of these patients will suffer from problems with awareness, problems with orientation, and they greatly benefit, this is our experience, from being verticalized as soon as possible, because it's a much better perspective you have if you are upright in an upright position compared to lying in the bed and watching the ceiling all the time. So basically, I think it's beneficial for most neurological patients. And even if you don't have a neurological condition, but face a longer intensive care unit stay with longer term respiratory care, you are likely to develop critical illness, polyneuropathy or myopathy. And it is quite important to start mobilization and muscle training early in these patients as well.
Okay, so that's the good news. So now we have also the chance to talk to an expert about early mobilization from a PT perspective. I would like to welcome our second guest speaker, Barry Ford. Hello, Barry. Can you hear me?
Hello, Doctor. I
Hello.
can hear you.
Great. So that's great.
Thank you for having me today.
That's great. Thanks for joining our webinar via Skype. So based on your experience, Barry, from a PT perspective, what are or why is early mobilization so important?
Well, you've mentioned a number of complications associated with immobilization, and I'd just like to add a couple of points to that. From a physiotherapy perspective, one of the biggest challenges we have in the neurological population is spasticity and loss of muscle length. Now, when patients are immobilized for long periods of time in the acute stage, quite often they can suffer with devastating spasticity, which can result in loss of muscle length, joint alignment problems, and pain. Now, if this isn't managed and patients aren't weight bearing, quite often it can result in contracted joints. Now, despite future improvements in muscle strength 3-4 months down the line, if patients have contracted joints and loss of muscle length, then they may never weight bear or stand again. So it's absolutely essential that as physios, we're trying to get patients up and moving as soon as possible. Just coming back to another point you made about orthostatic hypotension, in the spinal cord injured population, especially with high cervical injuries, if these patients don't overcome the orthostatic hypotension in the acute phase, they can quite often live for many years with persistent orthostatic hypotension, which can be devastating on their function and their quality of life. My last point, and probably the most important point, is around the psychology and well-being of the patient. From my experience working with people in the acute phase of care, there is a desire to be able to participate and become active in their therapy. And if they're unable to do so, however small the goal, quite often patients will disengage or give up on therapy. And despite making recovery 2-3 months down the line, quite often psychologically, they've already made the decision that they can't succeed with their therapy. So it's essential that we find a way of helping patients to mobilize and recognize improvements in the early stages of care.
Okay, so that sounds quite good. But what are, for example, the conventional therapy methods to mobilize bedridden patients? So what can you tell us about it?
So the first step in mobilizing a patient conventionally would be to hoist them out to a chair. The initial complication in critically ill patients is cardiovascular instability. So that's the first issue we have to overcome. The second stage would be to see if a patient can sit up by themselves and start to weight bear. As you can imagine, in a stroke patient with dense weakness, weight bearing in the early stage can be particularly labor intensive and difficult to support, and also very risky for therapists themselves. So quite often we will use a device called a tilt table. And the idea of the tilt table is that we can stand a patient and start to verticalize them very slowly. The limitation with the tilt table is that it is a passive modality, so the patient is not participating. And secondly, quite often with tilt tabling, orthostatic hypotension will still be an issue which we can't overcome.
Okay, so but how do you solve this issue? So you mentioned with the conventional therapy methods like a tilting table, there of course you also try to verticalize the patient as soon as possible, but you also see some negative aspects. So in your clinic, in your facility, what is the solution, or from your perspective, how to solve this situation?
It's a good question. Well, about 2 years ago, we purchased a new piece of equipment, and the equipment was called the Ergo Pro. And we purchased this piece of equipment and we carried out a feasibility study to see whether the Ergo Pro could be used safely within the intensive care environment. What we found from the study was that the Ergo could be integrated into the intensive care and it could be used safely. Since then, I've carried out a number of case studies to identify which groups of patients would directly benefit from Ergo training. I'd like to talk a little bit about those now.
Okay.
So the first group of patients which I've seen clear benefits from ergotherapy are those patients with orthostatic hypertension, specifically those with the autonomic orthostatic hypertension. An example of this would be a C5 complete spinal cord injury patient that I was seeing last year. He was constricted to the intensive care environment because of the severity of his cardiovascular instability and was relying on large doses of inotropic medication to stabilize his blood pressure. What we found was that with 3 weeks of ergotherapy, training 5 times a week, he was able to stabilize his blood pressure in standing, and subsequently we were able to remove the medication to support his cardiovascular system. The result of this was he was able to leave the intensive care environment. So time and time again, we find this device is superior at allowing us to stand and verticalize patients that show cardiovascular insufficiency.
Okay, so
the second
sorry. So you mentioned in terms of the outcome, there's some positive aspects, and but what exactly would be then the benefit of this advanced technology you've mentioned? So is there how does it support you as a PT to get to these outcomes?
Well, simply, patients with cardiovascular instability cannot sustain standing up on a tilt table or sitting out in a chair, as you said, due to low blood volumes and the other issues. This piece of equipment is able to improve venous return with the robotic leg drivers, okay? So as a result of that, patients are able to verticalize and sustain blood pressures. Not only do we see improvements in the cardiovascular system, but in those critically weak patients I mentioned, they're able to train within a safe platform, and we're able to reduce the intensity of the exercise so that they can participate. It reduces the number of therapists that are needed to manually mobilize someone. It eliminates the risk of what we have to do with heavily dependent patients, and it also allows them to achieve achievable goals. There's just 2 more groups of patients I'd like to talk about. That group I mentioned about spasticity being an issue. Quite often when you're lying flat in a bed, your perception of your body is distorted, and spasticity can become a real severe problem. What we found with a gentleman last week was we were able to mobilize him in the ergo device, and we saw improvements in his spasticity, in his Ashworth and his Tardieu outcome measures. And we also saw improvement in his hip pain. So again, this isn't something we'd be able to do with conventional therapy due to the labor intensiveness of the nature.
Okay, so on the one side, you can reduce the body or the negative consequences of long bed rest, but you can also improve the functional outcomes a little bit like this. Is it?
Of course. So you can improve the impairments, the spasticity, and the muscle weakness, and as a result, quite often, once patients are strong enough through ergo training, they can then recommence conventional therapy, which will be standing and mobilizing with a mobility aid.
Okay, so thanks for your input, Barry. So we've heard now several times about this ergo, and I would like to give you a little bit more insight now about this device. So thanks, Barry. You will be on the line later for the expert panel. Thanks.
Thank you very much.
In this animation, you can see how the ergo units the relevant aspects of safe and early mobilization for neurological and bedridden patients, all in one device. The robotic leg movement is combined with gradual verticalization and provides intensive sensory-motor stimulation. A cycling leg loading is applied to the patient during the robotic leg movement and further enhances the stimulation. This unique efferent stimulation activates the central nervous system of the patient and in turn stimulates the muscle of the lower extremities. A rhythmic muscle pump effect is induced, which helps to maintain venous return during verticalization and leads to a faster cardiovascular stabilization. The functional electrical stimulation further increases the muscle pump effect by supporting the leg muscle contraction. This combination improves patient recovery and offers therapists a safe and solution for early mobilization. So, Professor Bender, you're also working with advanced technologies in your Therapiezentrum of Burgau, mainly with brain injury patients, like traumatic brain injury, but also with patients with disorders of severe consciousness. So, can you give us also a little bit more insight about this patient population? So is it also beneficial for those patients?
Mm-hmm. Sure. So the basic principle in neurorehabilitation for these patients is that you want to stimulate them on as many canals as possible. And because those patients suffer from severe distorted perception, as Barry was saying, they suffer from spasticity, they're disoriented, and it has been an experience over the last 25 years in our center that the sooner you are able to verticalize a patient, the sooner he will be able to make improvements. You see this by decreased spasticity levels. You see this by improved head control. So indeed, we find several positive effects in patients with severe disorders of consciousness, more activity. And I have brought a video which could show this in an exemplary case.
Okay, so let's watch this video.
Yes, so this is a gentleman who had suffered from cardiac arrest when he arrived at our center. He was in an unresponsive wakefulness syndrome. He has improved by now. When this video was taken, you see his eyes are only half open. He has a feeding tube in place. He has a tracheostomy tube. Now he's being transferred from his hospital bed to the Erigo device by the mobilization team. They take the monitor for cardiac function and so forth with them. Now you see him still lying in the Erigo with the cyclic muscle movements already taking place. He's still not much influenced by this, it seems. His eyes are closed, and now you will see him being lifted up to a standing position, which happens gradually. Now you see him here. He still needs the cushion to hold the head, because the head positioning, head control is not okay by now. He looks a bit more awake, but not really a great deal. And now you'll see him a couple of minutes later within the same training session, I have to say. And you see the cushion is gone, so he has head control by now. You see his eyes are more open. He looks more awake and more participating in his environment. He tries to take in the environment. And I can tell you that, and you see he has eye movements and eye following. And by the end of this session, he was able to follow commands. Of course, this is just a single case experience, but we are conducting a large trial now to see if this is also scientific. There's scientific proof for this assumption.
So that's really an emotional and really a good example. But what are the relevant safety aspects for such treating patients like this example with an advanced technology like the Erigo?
Yes, so I think the first important thing is patient selection. So of course, even if you want to start as early as possible, it's not a wise idea to do this with patients who have increased intracranial pressure. So you have to be careful in your patient selection, but from our experience, it will be okay for most patients. And when we started working with this device, we were a bit cautious, and in many patients who had a bad day, you might say, with rather low blood pressure. In the beginning, we thought, this is not a good day for the device. But then we dared to do it in some patients, and we found out that the opposite was true, that the blood pressure stabilized in most of the patients, and the mucus and the respiratory function improved. So from a bad day, it went to being a good day. Of course, it's all about monitoring the patient while you do this, because you are early in the disease, the patients are critically ill. So you have to have a monitoring device in place for cardiac function, blood pressure, heart rate, respiratory function. And you have a very experienced team to be around. You cannot have the patient train and be upright by himself. He has to be monitored by personnel. And an important thing is you just have to take in his expression of the face and monitor him as a person and see if he's feeling well.
Right. So I assume also in your Therapiezentrum in Burgau, you have also other ways of to early mobilization, maybe also other technologies. But what is really beneficial now for such a device like the Erigo? So what's your impression?
As I've said, early mobilization and verticalization was always a key idea at our center. Mm-hmm. The methods have been mentioned by Barry. Yep. But what we found is, as in most therapies which have proven beneficial in neurorehabilitation, it's a matter of dosage. And I think the device in many patients can help to increase the dosage by having them standing up for a longer time, because you have the increased venous return to the heart and the muscle pump in action. So we found that patients could be mobilized for 30, 45 minutes, who before that were at the side of the bed maybe for 10 minutes and then had to go back. And we have patients two patients within the same room, and both are on the system. And it's also a motivational thing. So the one patient says, I have 400 steps today. The next says, I will get 450. And so they push themselves a little
Okay,
bit.
so it's also some kind of psychological factor, also like Barry mentioned. So it's really important also in the early stage of rehabilitation, to consider about this aspect. So.
Absolutely.
Okay, so before we start the expert panel, I would like to announce our next webinar. It's about modern gait rehabilitation, what a clinician needs to know. It will take place in September with a live session and also a guest speaker. The guest speaker will be Professor Alberto Eskenazi from Moss Rehab. So please also register for this webinar and save the date. We will announce this webinar and the time as soon as possible. So I'm looking forward to meet you also in this webinar. Now I would like to open the expert panel, and if you haven't addressed your question so far, so please use the chat function on the right side. So again, as I mentioned, you can address the question either to Professor Bender, to Barry Ford. He will also join us now again via Skype, and to me. Okay, so let's see if there are some questions from the audience. Okay, yeah. So it takes a second for the connections to get the questions. Okay. Okay, so we have a first question. It's from Carl Frederick Franzen. Are you also treating non-neurological patients with combined verticalization, stepping therapy? And if yes, what is your experience? Maybe I will give this question to Barry as a PT. Do you have some experience with non-neurological patients also in early mobilization?
I do. We have started to use the Ergo with the non-neurological population. Quite often, we had a patient, for example, in the intensive care environment who had septic arthritis, so severely swollen and sore joints, and as a result of not mobilizing, become profoundly weak. And he was unable, too weak to stand, and he had too much pain to stand up at that point. And again, what we found was, as Professor was saying, that we could really moderate the intensity so that in the first Ergo session, he completed only 10 minutes, but he was able to complete something. The second day, he was then able to complete 15 minutes and start to verticalize to 30 degrees. So for that profound weakness aspect, it was able to give him the sufficient support that he required. As a result of that, after 2 weeks of Ergo training, he was then able to stand and mobilize with a frame in a conventional manner. So we are using it with non-neuro as well as neuro.
Okay, great. Professor Bender, do you have some experience with non-neurological patients and early mobilization?
I think this is a very important topic, because one has to bear in mind that even if you start out not as a neurologic patient, if you are on the intensive care unit for, let's say, more than a week and you suffer from severe infections or sepsis and you are ventilated, then you have a very high chance of becoming a neurological patient. As a secondary condition, you will have a condition probably called critical illness polyneuropathy or myopathy. And this goes together with acquired weakness. And so in most of these patients, mobilization and verticalization is also beneficial, and we have several of these patients, and we use this concept with success in them as well. So I think it's also very important in primarily non-neurological populations.
Yeah. So maybe also to add a comment to the question of Carl Frederick Franzen, we have also now some experience with the first facilities in Garrett 3. So, and they also used the Ergo, for example, and the feedback is quite positive. So that's the first experience now, but I think there could be also some other fields where an advanced technology could be used for some mobilization and also for some verticalization. The next question is from Kumar Seth. He wants to know, we don't have patient lifts for transfer. Often often not even in ICU. So the transfer onto therapy devices could become a safety issue. So again, I think we're back with the safety relevant aspects. Maybe Professor Bender, can you tell us something about the transfer of a patient to this Errigo device? Is it a safety issue, or how do you handle it in your clinic?
Well, basically, I think if with almost all of the procedures you have with those critically ill patients, it's all a matter of planning. So the team has to plan ahead what the next steps will be in transferring a patient, take good care of all the tubes that are going in and out, and which are, most of them at least, very vital for the patient. So you have to take good care. Of course, it is a potential risk. But this is true for all the manipulations that you do with the patients, if you turn them around for respiratory reasons or for making the bed or whatever. So basically, it is a danger, and you have to have good planning. In our center, I might say, we didn't have a single serious event associated with the transfer to this device or any other device.
Okay. Maybe also comment from my side. So far the Errigo is on the market, I think, or is since 10 years on the market with more than 300 devices worldwide. And so far we are not aware of any critical issue regarding transfer or application of the device. Is this in line with your experience with the device, Barry, or?
I completely agree with the professor there. I think what we found from our feasibility study was it's essential to accurately identify how many members of staff are required for the transfer, making sure that the airway and other lines are secured. In terms of equipment, if a patient is on the bed, just with the use of a PAP slide, they can just be transferred across onto the Errigo. So it doesn't necessarily have to be done with hoisting equipment, but it is about being clear about staffing and the equipment that you require prior to the transfer.
Right. There's an additional question. It's from Kathleen Polly. What outcome measures are you using to measure patient progress in the acute care setting? So Barry, how do you monitor, or how do you report the progress of a patient? So which kind of outcome measures do you use?
So it completely depends on the type of patient that we're treating and on the problem that we're assessing. If I take the level of disorders of consciousness patient, for example, at the moment we use 2 recognized outcome measures to monitor responses in patients' responses. They are the Coma Recovery Scale and the West Sussex Head Injury Matrix. Essentially, both of these measures aim to monitor patients' responses and help us to identify if something is emerging from coma. Another example would be in spasticity. If we were looking at muscle spasticity, we would use something like the Ashworth or the Tardew, which are 2 standardized measures. In terms of function, if we were looking at something more around the function of the patient, we use assessment scales such as the FIM-FAM and the Bartel, which look more at the activity and participation level of what a patient can actually do for themselves.
Okay. Do you want to add anything? So it's, I think, or I assume more or less also the same outcome measures in your clinic, or?
No, I absolutely agree with Barry. I'm happy that we seem to be using intuitively the same measuring tools.
Okay. The next question, or it's again from Kathleen Polly. What alternatives are there to the Errigo lift if the equipment is not available in your clinic? Any comment on this question from your side?
Yeah, well, it has to be clearly said that, I said we had 25 years of experience with severely brain injured patients, and they have been mobilized and verticalized, of course, all those previous 25 years, even though we have only had access to the device over the last couple of months or year or so. And of course it has been done before. It's an individual decision of how to do it. If you want to get the patient to a standing position in front of the bed, we often make casts for the patients. So the casts go around the legs, stabilize the legs. Then with help of 2 or 3 therapists, the patients will be mobilized into a standing position, leaned against a conventional standing device. The problem with that is that patients can quite often only endure this for a couple of minutes and not much longer. they make improvements with that, but we found that increasing the dosage is of essence there.
Okay. The next question is from Wiebke Wagner. She wants to know, how do you prioritize between mobilization and facial-oral tract therapy in patients with tracheostomy and dysphagia? In our unit, physiotherapists also handle dysphagia, and it can be difficult in 1 hour therapy to mobilize to standing and also to manage the cuffed tracheostomy. How do you do this?
Yeah, I can say that this is, of course, a constant area where you have discussions with the whole team, with the therapists, with the other doctors. So I think this is a decision which has to be taken individually for each patient. We always try to combine different therapy specialists in one setting. So in the case of the verticalization with the Irigo, we do that with help of a PT, and then we often have the speech and language therapist come to the same session and work with the patient on the swallowing function and the oral and orofacial functions. So we try to combine this, and I think you just have to prioritize. I think if your main goal at the moment is to have an unconscious patient, who's maybe in an unresponsive wakefulness syndrome, to become a responsive patient, I think there's not much more beneficial things you can do than trying to verticalize them as soon as possible.
Barry, what about you? Are there also some discussion in your team or in your facility how to prioritize? Or do you have also some requirements or guidelines, or how do you choose and select?
Sure. We as a team, we have a team meeting basis with the patient on a monthly basis, and within that team meeting, I'm quite keen for the patient, if they're able to express what is priority for them in terms of their wish. So if, for example, it is to get weight bearing, then we can focus the team around that. If it's around tracheostomy weaning or around speaking, then we can try and put all of our resources into that area. In the case of where a patient isn't able to communicate, then we would do it based on our clinical judgment, as the professor said, in terms of what would be most beneficial based on our clinical reasoning at that given time.
Okay. So the next question is from Lina Source-Emilson. She wants to know, from a neuronal plasticity point of view, it is known if it can be harmful to start rehabilitation very early, and if so, what is very early? 24 hours, question mark. And what are the hypotheses why it could be harmful? So, Professor Bender, what do you think? Could it be too early, and what is too early, and why could this be harmful?
There is certainly some truth to that, because it has been shown in a study that starting very early might at least not be beneficial, or maybe even harmful. This was one study. There are several other studies which have shown that it can be performed safely within even the first day. So I think the verdict on that is still out, and I think there is no such thing as one specific starting point which is right for every patient. I think this is where we as professionals in the medical field come in to judge when a patient is able to do that. So of course, if you have a patient who has a space-occupying malignant stroke to the left or right hemisphere, which is still in a critical condition on the first 1, 2, 3 days, we would not try to get this patient to an upright position. We would maybe start mobilizing by using a bed cycling device, ergometer device, and in other patients you can do it safely. I think what would be probably not according to the current literature is that for safety aspects, you start in all patients late, just to not do some harm to some patients, and late is like in week 2 or 3. So I think the aim should be in most patients to be active in some sort on day 2 or 3.
Okay. So Barry, what about your experience? When do you start early mobilization? Is it within the first 24 hours? Is it a little bit later? Or what is your opinion about this, to do it too early?
Here in the UK, we have a national guideline, and part of the national guideline is that we commence a short assessment within the first 24 hours. And within that 24 hours, what we're looking to assess for is the patient's ability to participate in some form of rehabilitation. In terms of the decision to commence early rehabilitation, it would be made as part of a multidisciplinary team decision. So in line with our consultants, our nurses, our occupational therapists, it's a joint decision as to ascertain when would be a safe point to do so. I think the key is, in terms of any form of early mobilization, that the dosage is correct, because what we can see in the early stage is if the intensity isn't correct, we can see signs of fatigue, and fatigue can have a negative consequence on neuroplasticity at that point. So I think it's taking things slowly and managing our doses appropriately.
Okay, so to summarize this a little bit, it's like you should start as early as possible. You should really also start maybe also in day 1, day 2, but then really to play with the dosage, to make maybe shorter sessions and more frequent sessions instead of a long duration to increase the fatigue. So is this a statement we can give, or?
Yes, I could agree to that.
Okay. So a next question is from Michael Frank. How do you handle training with isolated patients? And I think that's also maybe you both work in different facilities, maybe you have different approaches. So Professor Bender, what is your approach in your facility with isolated patients?
Yeah, in those cases, we would actually go with the traditional methods of mobilization. We would not use devices just because it's difficult to get them disinfected again. So this would be one situation where we go for the traditional approaches with the casts and the standing tables, so forth.
Okay. What about you, Barry? Do you want to add something, or do you know other facilities about isolated patients and how they do it?
I think if there is a real clinical need identified, then we would try and use the ergo at the end of the day, so it would be the last patient, and then we would remove the harness and have it washed sufficiently, and hopefully the device cleans at the end of the day. Otherwise, we would pursue conventional methods.
Okay. We have an additional question from Jose Tovar. He wants to know, do you have any experience in the use of the Arrigo on non-acute patients while engaging upper limb as well? Any experience, Professor Bender?
Well, we also see patients who had their brain injury several months and even years before they come to us, and other patients come to us in the early phases and stay for several months, so they are not longer really acute patients. And we use verticalizations in those patients as well, because I think many of these patients will suffer from severe spasticity, as Barry was saying. I think this is a very important point, and they just benefit from being in a normal upright position. And as I said earlier also, once they are in this position and once the muscle tone is decreased and they may have function, at least some function in their upper extremities, we will try to use that combined with ergotherapy, for example, occupational therapy, and try to make the use of the standing position in that circumstance.
Okay. Any comment from your side, Barry, about the non-acute phase? Do you use the Arrigo for such kind of patients or in this phase of rehabilitation? Any experience?
Sure. We're separated into two departments, and in our long-term rehab department, they also have the first Ergo device. Coming to the point that the gentleman made with regards to upper limb function, quite often patients' upper limb function can be quite impaired because their trunk is weak or they have a weak trunk. And what we know with verticalization and standing is that it can help to stimulate the extensor tracts and improve trunk alignment and activity, which can subsequently improve upper limb function. So I think the Ergo would be one way in and improving trunk strength and helping improve goals towards upper limb function.
Right. We have a next question from Kathleen Polly. Thanks for your many questions, Kathleen. The Arrigo is largely a passive modality. Clearly, it is helping the patient in terms of being more awake, but is there research supporting this modality related to active participation and functional outcomes? So maybe Barry, you already mentioned that there is some potential for functional outcomes and that you also use this in your clinic. Do you know any research, or can you comment this on also your experience with the device?
I think, yeah, again, I think it's more based on experience than literature at this stage, because the device is still fairly new. I think in terms of the device being passive, it all depends on the patient. If you have a patient that can actively participate and is able to use the muscle strength they have, then we can actually reduce the assistance of the ergo on the lower limbs, allowing the patient to be active with the process. In terms of functional outcomes, as the example I used before, quite often if patient is confined to the bed and they're too weak to sit or stand, after using ergotherapy where they're able to actively participate in lower limb exercise, quite often functionally they're then able to stand and to take first steps thereafter.
Okay, so maybe also comment from my side, Kathleen, to your questions. So I think our clinical research department would be also able to get in contact with you directly to maybe to also deliver you the latest research and all important information to give you a little bit a better insight into the status of research of this device. So maybe that's also an option. Are there any further questions from the audience? So I also see that we are now also that the time is also over of the webinar session. So if you had some additional questions and they didn't pop up on the list, or we didn't answer it directly now, we will come back to you via email and we will try to answer your questions afterwards. So I would like to thank Professor Bender for your participation, for your time to join us here at the studio for this webinar. It was really a pleasure to have you here. Thank you very much.
It was a pleasure being here. Thank you very much for having me.
And also, Barry, thanks to you for your time and for your insights into the integration and application of advanced technologies into your facility. And also, I think both of you are the main message is that early mobilization is really a key aspect in rehabilitation, and it's also in a safe environment. So we are not talking about a critical situation. Early rehabilitation should be part of the treatment, and it's really a key factor for successful rehabilitation. So thanks for your time. Also thank you for your time to join our webinar. I hope you had some fun. You learned some additional things. You had a good insight. As I mentioned, please also join our next webinar. Have a good time. Have a good day. Bye-bye. Bye.
Bye-bye.